Well, in the modern era, our AF ablation techniques have got better, and we've just presented a study that suggested that in successful AF ablation, then maybe they don't need an anticoagulant. So theoretically, in that cohort of patients, we've got another alternative way of doing things rather than putting a closure device in. Patients who've got a closure device in, it can be then subsequently tricky to do ablations. So I think we're just looking at this the wrong way around. So I suspect this is a niche device for a niche group of patients.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to the season finale episode of Parallax. We've sort of done this for 7 years now, and for the last 7 years, we've had our guest, Dr. Nijjer, who does this episode for us and sort of has been, if you look at the metrics, which I just did with Radcliffe, has been one of the most downloaded episodes every year. So Sukh is an expert and does an incredible job with summarizing the year from a cardiology perspective for all of us at Parallax. And I don't think he needs to be introduced. Sukh is, Dr. Nijjer is an interventional cardiologist at Imperial College in London. And he's also a senior clinical lecturer at the Imperial College. So without much further ado, Sukh, welcome back. Thanks for doing this for us now for 7 years in a row.
Wow, it's amazing to hear that timeline, Ankur. Yes, it's great to be back and glad to join you over this festive period.
Yes, no, I sort of look forward to this. And, we did this in person. I think that was like 2 years ago or maybe 3 years ago. And we've sort of maintained this, for lack of a better word, ritual to do this with you. And, I really enjoy the potpourri of trials that you put together for us and to summarize the year in cardiology. So we'll start with post-myocardial infarction and heart failure therapeutics. It's been quite the year, I think, for beta blockers in acute MI. And so I'm going to have you tell us more about what you've chosen for us.
Yes, absolutely. So you're absolutely right to say that it's been quite an up and down year. Sometimes even in the same Congress, there are conflicting trials and confusing endpoints that leads to a little bit of concern and worry. But I think overall, the message when we combine the information together is pushing in the same direction. So there were two big studies that were presented at the European Society of Cardiology meetings this year. This was probably the biggest meeting now on our calendar. And this looked at the use of beta blockers after myocardial infarction. And this is a source of debate. We've known for many years that beta blockers help, particularly when there's multiple territories left unrevascularized after myocardial infarction, or patients have poor left ventricular function, people have extensive scarring, or those with significant arrhythmia. Say, for example, they may be having runs of ventricular tachycardia, they may well have extensive scar. And then there are all sorts of other indications for the use of beta blockers. They may well have atrial fibrillation. They may well have other reasons to have beta blockers. And so the use of beta blockers, particularly here in the United Kingdom where I work, is part of a quality metric, and all of our patients are audited and the data gets submitted to national bodies, and they look to see how many of our patients are on beta blockers. But the key question is, do they all need to be on beta blockers in the modern era? Heart attack treatment is very different. I always think back to when my grandfather had a heart attack, and I ended up actually choosing medicine and cardiology as a consequence of what happened to him. And this was a very different era. They didn't even have coronary angiography. They were treated with bed rest, and it was an era of just anticoagulation with very little other treatment. This is a very different cohort of patients in the modern era, where particularly here where I work in London, door-to-balloon times for coronary angioplasty, the primary angioplasty setting is very short. We're often talking about pain-to-balloon times of less than a couple of hours. So this is a very rapid turnaround, and patients sometimes don't even know they've even had the event, and yet we're still judging them on being on beta blockers as a key metric. Now, what this naturally leads to this question, and then this led to a number of different studies. So there was the Reboot Sync study, and there was the Arrival study that was also presented at the same time. That was the Beta MI down block study. And these looked at patients who have had a myocardial infarction, have had complete revascularization, so modern PCI, modern early treatment, and they've had an echo in the straight after the MI setting in which the EF is more than 40%. Patients very well, they've got no heart failure. And in the Reboot study, they're randomized to routine long-term beta blocker therapy versus no beta blocker therapy. These patients have been followed up over a period of time. The primary endpoint is a composite, as is often the case with these studies. As you know, endpoints have to be composites because the studies can never be large enough to have pure mortality endpoints. And they look at all-cause death, recurrent MI, or hospitalization for heart failure. And in the Reboot study, what they were looking at is patients coming back in with either heart failure or recurrent MI or all-cause death. So these are fairly hard endpoints. These are the kind of endpoints that matter to us as clinicians and the endpoints that matter to patients. And what they found was there was no significant reduction in the primary endpoint when patients are on beta blockers compared to when they're not on beta blockers. Now, it's a challenge because this is overturning a lot of inbuilt process that we've done for many years. As I've said, here in the UK, it's a quality metric. These patients are given beta blockers. It causes a lot of angst because sometimes we have physically fit patients who've got heart rates down to their 60s. Adding in a low-dose beta blocker certainly is probably only making the doctor feel better in themselves, hitting the quality metric rather than helping anything to do with the patient. And so when we see these kind of studies that show that there's no added benefit for giving a beta blocker in the modern era, many of us feel quite reassured when we choose not to give a beta blocker. There are some nuances and some points here. Of course, this is a relatively well cohort of patients. These were all patients that had a relatively good ejection fraction at the end of their myocardial infarction. And as we know, early echoes are not usually the endpoint echoes. If you repeat an echo at 3 months and 6 months, many of these patients will have very much a normal ejection fraction at that point. So what we can conclude is in relatively well patients with a good ejection fraction at the end of their MI, there's little value in adding a beta blocker in that cohort in the context of these patients being quite well. And then there was a slight confusing signal at first glance, if you look at the headlines, from the down block study. So it's a beta MI down block study. This is from Scandinavian studies, centers rather, from Denmark and Norway. And they had a very similar cohort of patients who are quite well. They've just had a heart attack. They've got an ejection fraction of more than 40%. They're quite well. And this is whether they have ongoing long-term beta blocker versus discontinuing the beta blocker. Looked at similar endpoints, and they found, again, not much of a difference. Now, the headlines that came out at that time confused everyone. It certainly confused me when I was looking at it. And they suggested that those patients who are in the 40 to 49% group seemed to have a benefit compared to those who had ejection fractions of over 50%. But actually, when you really boil down the subgroups and you look at the subgroup analyses in details and look at the actual number of events in this down block study, they're tiny, and the total number of events that are occurring are really, really quite small. So it becomes quite hard to be certain about any of the outcomes of these studies when the event rates are so low and the number of patients in each arm is very low. And 1 or 2 events going the other way would have altered the outcomes of the study. So when we look at the totality of the data between these 2 rival studies, is I suspect everything is pointing in the same direction. That the majority of patients who've had a myocardial infarction, where the ejection fraction is reasonable, the patient is well, the absolute indication for a beta blocker in the modern era seems to be less. There may be other good reasons to give a beta blocker, and obviously as a clinician, you're going to have to look at that carefully, but it's not an absolute must. How has that affected your practice, Ankur? Is that something that you've changed in what you do?
So great summary. So I sort of started to change my practice when I think the very first trial, which was presented, I believe in 2024 at AHA, was published in the New England Journal of Medicine, where it demonstrated that in patients who had preserved LV systolic function post-MI, after primary PCI, and like you mentioned, some of the quality metrics that are reported or mandatory to be reported to national societies in the UK and in England are very similar to what we do here in the US. We report them to the National Cardiovascular Data Registry. And so beta blocker is a cornerstone quality metric. At times it sort of becomes ironic that we have to, add a whiff of a beta blocker just to check off a quality metric more than anything else, because patients, the LV function is normal, they're normotensive, heart rate is, the range is anywhere between 60 to 70, and you wonder why even prescribe them a beta blocker, and then you sort of have to check off that quality metric. So I think, and we find these patients, what I just described is not infrequent. And so when that trial was published in the New England Journal, I started changing my practice and sort of commenting in my note, why I feel a beta blocker is not necessary here. Now, you do mention there are some important, clinical comorbidities or, intercurrent illnesses, like maybe 15 to 20% of these patients, their clinical course is complicated by new-onset atrial fibrillation. Sometimes these patients have long-standing benign essential hypertension. And so in those patients, for sure, I think it sort of checks multiple boxes when you prescribe them a beta blocker. But otherwise, if the ejection fraction is normal, in my practice, I'm not prescribing them beta blockers anymore, even after the acute setting.
I think that's very sensible. Obviously, every bit of care has to be individualized to the patient. We have a lot of patients who are relatively fit, young people in their late 40s, early 50s. I can think of example patients just from the last week I was on what we call the wards, you guys will call the floor. I was on the wards and had several young guys that had heart attacks, either end STEMIs and one STEMI patient, both well, actually quite sporty people. Resting heart rates were relatively low, blood pressure was normal, very little need for a beta blocker. And yet, the push from our allied healthcare professionals, because they've got to complete their cardiac rehab boxes, they've got to tick all the various bits, is, why haven't we given this patient a beta blocker? And then we end up giving tiny doses here in the UK for reasons that have never been entirely clear to me. We give a lot of bisoprolol. Bisoprolol, I know, isn't the default in other countries, but we use it a lot here. And so we end up giving a tiny dose, 1.25 of bisoprolol, simply to tick a box, not really to help the patient. And then if there's continuity of care and you see these patients back again, I always hear the same things. People are worried about taking beta blockers because they've looked them up or they've seen some video that tells them that it's very bad. Ironically, there are young kids here who are obsessed with taking beta blockers. There are lots of young people here in the UK after watching TikTok videos who are taking propranolol. I'm not quite sure why, but it seems to be a trend. We have these patients who are in their 40s to 50s who've been prescribed beta blockers and suffering with erectile dysfunction, tiredness and fatigue, or inability to concentrate. And deprescribing does help. I have a bit of a bias. I want to minimize the number of medications I give to patients, particularly if it's not necessary. And I think getting rid of the beta blocker would be an easy win for us in many of these cases.
Yeah, no, absolutely. So moving on, what did you pick for us in heart failure? This was I think a very interesting trial presented at AHA by Ambrish, who's a really good friend of mine. Was the paper published?
Yeah, so the paper's not published. So this was the PolyHF study. And the reason I picked it was because it's just part of, again, a little bit of my bias, and the listeners who've ended up listening over the years will know I often end up picking a polypill type paper because I think adherence or compliance with medications is one of the weakest parts of healthcare. And that part where we really fail to make a big difference. I'm always struck, and I was really struck as a PI of a big study we were doing. And in this study, these are patients who had volunteered to be in a study. So they're a highly motivated group of patients, and they've volunteered to take an additional pill because we've told them it's going to make better for their heart. And when as part of this study, we had a small device that could detect how many times the box was opened. And we found in this motivated group of patients only 30% of the time people were opening the device to take a pill out. And so adherence to medications in a highly motivated cohort of patients was really quite low. And I think this is the Achilles heel of a lot of what we do with medications. And so I think polypills are a solution, not necessarily the only solution, but a solution. And there was a very nice study done out of Texas. It is very small. Yeah, it is a highly niche cohort of patients, and I can understand how heart failure specialists will look at this and say, well, it's not applicable to my cohort of patients, or we do things differently. But it was a nice study nonetheless. So this was a study of, I believe, around 300 patients or so in the Texas area, being delivered by a coordinated heart failure team, in which they randomized them to a standard of care versus a polypill strategy for heart failure. All the patients were on a combination of an ARNI, so sacubitril valsartan combination, and then they were randomized to a fixed dose polypill, which contained a beta blocker, which in this case I believe was metoprolol, a spironolactone, so RAS inhibition, and an MRA essentially, and by giving them this combination of these medications, we were looking to see what happened to their sense of well-being, so Kansas City score questionnaire, but also their ejection fraction measured by both echo and MRI. And what was quite striking was this was recruiting predominantly a socio-economically deprived group of patients. A large group of patients were from ethnic minorities and from without a background of insurance and the kind of coverage that is so important in the United States that really affects the type of care that patients get. And we all know that in patients who are well insured in the US, it's easy to provide them treatment. They may well have a copay, but it'll be easier to prescribe. In patients without it, then getting some of these medications is very tricky. Compliance is tricky if they won't refill the prescription. What we found in this very small study was adherence was much higher, and that we found that ejection fraction improved, and it improved quite considerably. So there was a delta of around 4 or 5% on the ejection fraction, and there was improvements in the KCCQ questionnaire as well, and adherence. And although we worry about polypill type approaches where we think, okay, well, the patient may have a side effect and we won't know which drug is causing the side effect, in fact, this wasn't the case. We didn't see any dramatic increases in hyperkalemia or in worsening renal function or in hypotension, which is the main area that people worry about. So I thought this was quite nice and suggests that for a group that is deprived, in a group that hasn't got all the means and the facilities available, that actually we can deliver high quality heart failure management in a limited in a really limited way, i.e. just 2 pills, but get big gains in their outcomes in terms of improving their sense of well-being and improving their ejection fraction, which these are key markers of our therapy, aren't they? These are the key targets that we have as our therapies. Not an outcome study, not looking to improve death and outcome, not looking for hospitalization, because there's so many different factors involved, but nonetheless, a nice, practical, pragmatic study that could be performed in healthcare systems anywhere in the world.
Yes, I'm glad you picked this study, so because I think, and kudos to Ambrish and the investigators. You mentioned that they were socioeconomically disadvantaged, and yes, they 54% self-identified as Black, 33% Hispanic. We know that we particularly, the literature around disparity in healthcare started to come out, and unfortunately in leaps and bounds during the pandemic, and we've learned that Blacks and Hispanics were disproportionately affected by the pandemic, and so to have a randomized clinical trial around implementation science, specifically enrolling a lot of these patients from these races. Also, about 70% were uninsured, about a third had housing instability, about more than a third had food insecurity. So really, I don't want to use the word disadvantaged, although, it is disadvantaged. I think just vulnerable is the right word, a socially vulnerable group of patients. And in them, after the polypill was administered, and I think what I found to be really neat was that they did blood testing for all the components of the polypill, which, like you mentioned, included a beta blocker, MRA, and an SGLT2I, and then sacubitril/valsartan was a different prescription. All participants were on sacubitril/valsartan, and they found that those who were on the polypill had a significantly higher detectable levels of, both the metoprolol and the spironolactone in comparison, like only 54%, which was in the standard care group. So I have been looking out for this paper because, again, it's incredible implementation science, and also it's conducting a randomized clinical trial in a patient population which may be very hard either to access or to medically care for because of lack of medical insurance.
Yeah, I think it's really neat. And yes, I should absolutely just to clarify what was in the pill. So they had metoprolol, they had spironolactone, and an SGLT, and the SGLT2 they used was empagliflozin. So these are all medications that have been proven in this cohort, and can be used at fixed doses. And so that means would work really well in a combined polypill without needing much dose titration. And I think it also fits in. You'll remember there's been a number of studies over the years that look at, can we start these drugs rapidly in a single sitting and up titrate? And there's been a number of studies that have been done in Europe and in the United Kingdom that have demonstrated that it is feasible to start these medications in one go, in one bang, in lots of patients, and then up titrate rapidly. And so that all fits in with the fact that when we've identified heart failure, we've identified that there is a reduction in ejection fraction, getting people onto these medications rapidly, and doing the least number of visits and face-to-face interactions with them can actually lead to an improvement. And that's important in places where the healthcare system is constrained. So you could imagine if this was now rolled out to the Indian subcontinent, where there's huge numbers of patients who don't necessarily have access to high quality healthcare, that this could save and help so many patients. You could imagine across China, in which there have been some interesting studies looking at polypills for hypertension and other aspects of healthcare. You could just imagine how much of an impact this would have. And so whilst those of you who are in healthcare services that are well financially supported, they'll say, oh, well, I always up titrate this and I check this blood test and then I bring them back and I check the blood pressure and lying standing blood pressure. In fact, these studies show that you can achieve a lot without any of that. And I think that's helpful because it helps simplify healthcare going forward.
Absolutely. So we're going to move along from post-MI and heart failure to atrial fibrillation, which, I think has been a big year for how do we manage atrial fibrillation. You've picked two really interesting studies. We'll start with Ocean, and then we'll finish with Closure AF, which has been very controversial. I chuckle because, and we'll sort of talk more about this when we are discussing Closure AF. Personally, to me, the results for Closure AF were not surprising. Because I have not been in all these years been a believer of the device. But we'll start with Ocean first, and then I'm sure we'll have plenty to talk about Closure AF.
Yeah, so let's talk about Ocean. Ocean's a little bit more straightforward. It's something that I think a lot of people will have this question. They'll be asked by primary care physicians, they'll be asked by patients, they'll be asked by everyone, because we identify a patient with AF. Most of the patients who are put forward for ablation tend to be symptomatic. They've had documented atrial fibrillation, they've got an elevated CHA2DS2-VASc score. We send them for an ablation. Particularly with some of the new advanced AF technologies, I've seen some incredible success from my colleagues using PFA approaches. They return the patient to sinus rhythm, the patient feels a lot better. And then the natural question is, can I stop this anticoagulation medication that we're taking. Now, in the days of, if you're old enough, so sadly I am old enough to remember the days of warfarin therapy and the pain that using warfarin or Coumadin-based therapies would have, variable dosing, variable blood tests that had to be done multiple times a week, then actually there was a huge incentive to remove the anticoagulation, and lots of patients would come off warfarin. Then in the DOAC or NOAC era, there was an evolution of our thought process, and we became very much focused on continuing the DOAC because the feeling was the overall long-term stroke risk was based around their CHA2DS2-VASc score. Okay, so and CHA2DS2-VASc as an acronym has changed over the years, but our thought process is the same. These patients have got an underlying risk factor for stroke because of their totality of the substrate. There is a high risk of recurrent short spells of AF, and that poses these patients of longer-term risk of atrial fibrillation and stroke, and therefore we tend to continue with them on DOACs. And so my standard advice was in keeping with the general thought process regarding this. I'd say, yeah, okay, yes, you've had your ablation, but your CHA2DS2-VASc score is 3, and therefore I should be continue on rivaroxaban or pixaban or doxaban, whichever the agent the patient was using. And what the OCEAN study looked at was exactly this group of patients who've had a successful AF ablation, and they randomized them to either taking rivaroxaban, and they used, I don't quite understand the rationale for this, but they used a lower dose rivaroxaban than we would typically use. So in the UK, certainly our practice is to give 20 milligrams of rivaroxaban and only to down titrate to 15 milligrams if there is a level of renal dysfunction. In this study group, they chose to give 15 milligrams as the anticoagulant of choice versus giving aspirin. Now, again, that's controversial in itself because we know that aspirin is actually not a very good protector against stroke. We know from the original, I think the Evora study quite some time ago now, that showed that aspirin was nowhere close to cutting the mustard for stroke prevention, particularly compared to the DOACs. But I think it is something that many primary care physicians will happily prescribe. It is what a lot of cardiologists will fall back to for the want of something better. There is a bit of a debate over whether you could use clopidogrel or not, but this is what the study is, and this is what we have to deal with. And what they did, were taking around 640 patients per arm, was then randomize them to either rivaroxaban or aspirin, and then track them over time to see if they have stroke, any evidence of other embolic events, any bleeding issues, or any all-cause mortality. And this study ended up having to be stopped early because of futility, and because it didn't look like any favorable outcome was going to come from this study in the rivaroxaban arm. And in fact, there was a increased bleeding event rate in the rivaroxaban arm. So the safety committee felt that they had to stop this study early. Now, whenever you stop a study early, that means the study loses power. And it means that, and remember, whenever we power these studies, we tend to take slightly optimistic views of the event rate. And then when the event rate itself is low, that further lowers the power of the study. And so extrapolating the data then becomes quite tricky. And then when you also factor in the choices they've made in this study, in which they've used an unusual dose of rivaroxaban, and they've used a comparator that perhaps isn't the standard of care, so aspirin shouldn't be the standard of care as stroke prevention in patients with previous atrial fibrillation, it does make it a little bit tricky to understand and to be able to put into our modern practice. But the upshot of it was that there was no added benefit by taking rivaroxaban over aspirin over this time. The event rates were low, and the absolute risk differences were very, very modest. And you can argue over whether any of these numbers actually mean anything at all. And you can argue over whether you should put both ischemic and bleeding events in a primary endpoint, because they obviously pull in different directions. Two very different endpoints. Probably should design these studies so there are two separate primary endpoints rather than one co-primary endpoint. But it does suggest that actually in patients who have had an atrial fibrillation ablation, who have not had further runs of AF after their ablation, who've had some form of Holter monitoring, which is what the study required to get into the recruitment, that shows no AF, that it would be reasonable to consider no anticoagulation. Now, this will almost certainly lead to lots of debate. There'll be lots of people who feel strongly against this in both ways. But this is a helpful study to help answer that question that we commonly get asked by patients and by other referring physicians. What are your thoughts on this, Ankur?
Yes, again, important study from an implementation perspective. Get asked this question all the time after patients have had, if not one, at least two. I don't know if pulse field ablation therapy changes that. Usually with prior modalities for atrial fibrillation ablation, you would need at least two, if not, certainly more than one procedure. So probably two procedures to decrease the overall burden of atrial fibrillation. And then, patients will ask you, am I still required to be on the blood thinner? Because, I agree with you. Like when I was a resident, we were prescribing warfarin, and then we had the advent of, DOACs, which they're not novel anymore, but direct oral anticoagulants or non-vitamin K oral anticoagulants, or NOACs, in comparison with warfarin, showed greater adherence, less nuisance, because you didn't really have to alter or worry about a change in the level of the medication if you altered your diet or interaction with other medications. So relatively safe, easy to use, predictable, and superior outcome, even with regard to some of the bleeding events. Still, patients don't like to be on blood thinners. I don't think I would like to be on a blood thinner. So if there's an opportunity to get rid of it, then, certainly I think it's a valid question our patients ask of us. And, this study provides benefit, not benefit, it provides evidence that there may be benefit in stopping these blood thinners if you've had a successful procedure for, ablating the atrial fibrillation. I'll have to get into the nuance. Sometimes it also depends on which anatomic structure was ablated, whether it was the pulmonary vein, or it was the posterior left atrial wall, or the cavo tricuspid isthmus. The vast majority would be isolating the pulmonary vein, greater than 90%, and that has a good success rate. Has the trial changed our practice? Look, I can tell you that it hasn't mine so far. I'm sort of leaning on my electrophysiology colleagues to sort of guide that discussion with the patient. Has this changed your practice? Particularly in patients who have, say, for example, and a lot of these patients, again, I want to say between 17 to 20% of these patients have concomitant coronary disease and have had prior stenting and are on some form of, antiplatelet monotherapy, whether it's aspirin or whether it's clopidogrel. And in those patients, it becomes an even more important question. Should you then stop rivaroxaban or apixaban or edoxaban because they're on aspirin already, which is what the trial showed.
Yeah, this is the key thing that I have. So I haven't changed my practice just yet. I've been relatively happy with the safety of the NOAC medications. It is rare for us to see major bleeding events on patients with NOACs. And they do occur. And we obviously deal with a very older and sick, frail cohort of patients, and they do have events. My own grandmother had a massive a subdural hemorrhage after a major fall, but was on apixaban therapy and remarkably has done quite well and is back on apixaban. These things frighten the life out of everyone, but they patients can pull through with the appropriate care. In patients who've got concomitant coronary disease, we've already altered what we do in a lot of these cases. So whereas before we were obsessively giving triple therapy and then we reduced that down to dual therapy, and now, as we have seen with a number of antiplatelet studies over the last couple of years, is that we can even de-escalate that. And in a lot of patients who have AF and concomitant atrial fibrillation or paroxysmal AF, I've actually been satisfied with NOAC alone in a substantial proportion of them. Not all, depending on the anatomy, if they've got complex bifurcations or, I'm really worried about a particular level of calcific disease, then I will maintain them usually on clopidogrel alongside the NOAC. But there are lots of patients who can manage with just NOAC alone. Now, if we then start stopping the NOAC, then that particular cohort of patients are going to need to have something to protect them from the coronary point of view. So this won't apply to everyone, but it will apply to the middle-aged patients. So we're talking about those people, typically men in their 50s, who've developed atrial fibrillation. It may well be their only predominant cardiac underlying condition. They've got relatively low CHA2DS2-VASc score. The CHA2DS2-VASc score in this study was about 2.2, so not super high. And it suggests that in this cohort of patients, we can theoretically allow them off. You'll be surprised when you see a lot of these patients, when you talk to them, they say, oh yeah, no, I saw insert random doctor here in another city, and they told me to stop it. And so I've stopped it. I've not been taking it for 6 months or a year. And, the patient's been fine. So I think this does happen. This study gives you a little bit of reassurance and people don't need to panic. We have a lot of patients who get sent in after they've seen primary care and someone stopped their medications, and they get sent in as an emergency. They could have a stroke any minute. I think these studies give us a little bit of reassurance that that's not going to happen.
Yeah, fantastic. So let's get to the controversial trial of 2025, which, I think it's sort of is going to remain the most important, in my opinion, the most important trial of 2025. I think the other one, which I don't think we're discussing in our summary episode, but according to me, was another important trial, was Aquatic, which showed that patients with chronic coronary syndrome who also have atrial fibrillation, that dual antithrombotic therapy prescription, increases mortality. So it's good to stop aspirin because it had an increase in bleeding. So I'm not going to get into Aquatic, but we're going to talk about Closure AF. What do you think about Closure AF, Sukh?
Yeah, so I'll declare my bias up front. So I personally have not been a strong proponent of left atrial appendage closure. I've found it an unusual approach. Often these patients end up having closure devices, but then continuing on anticoagulation. We've seen lots of patients who've had the device fitted, and yet they develop thrombus on the device, which is, of course, completely the opposite of what you want. The waiting times, certainly in our local system for the closure device, is so long that some of these patients are sitting on anticoagulation, apparently who have a high bleeding risk, and yet are maintained on anticoagulation sometimes for a year, sometimes 18 months, and have had no bleeding events. And so clearly, therefore, their risk of needing the anticoagulant removed is clearly not there, and it's all a bit nonsensical. But I know it's something that's pushed very heavily in the United States, and there is a big push for closure devices, much less so here in the United Kingdom. So the whole concept of a Closure AF study was that it's a multi-center randomized control study, open label, however, albeit with blinded endpoint adjudication of the events. And they're looking at patients who are in atrial fibrillation, but have a very high risk of stroke, and they've got a very high risk of bleeding. And the question is a left atrial closure device non-inferior or even superior to medical therapy alone? So the question is by putting a left atrial appendage closure device, is that going to mean that you can avoid taking any form of oral anticoagulation? And the endpoints that are looked at are the kind of classical endpoints that you would expect. So ischemic stroke, embolic, systemic embolism, major bleeding, and all-cause mortality. And I think it's the detractors of these studies have been always very clear that this combination of endpoints causes a big problem here, because you're combining endpoints that move in different directions. So major bleeding and stroke, which is an ischemic endpoint, together as one thing, which then means that you will really bias your results. And it can be tricky to unpick the results. And what they essentially found is that it was not non-inferior. So that eclosure AF does not meet the non-inferiority endpoint to medical therapy. And so that then essentially means that these closure devices are not as helpful and are much harder to justify in modern practice. And so I think this is for me, this suggests that there's very, very little utility for these devices going forward. I know there are lots of different ways of interpreting these results. What were your thoughts?
Yes, Sukh, I'm completely on board with what you said. I have my own bias has been that I've not been a believer. I did not personally offer them to patients. I did not prescribe them to patients because I've been in practices where both interventional cardiology was doing these procedures, and then I've been in a practice where our EP colleagues were offering the device to our patients, and I would present my own. I don't want to say belief because we've always had data, supporting our bias, and so I would present my interpretation of the data and what I felt with patients, and then I would let them have a conversation with the person who's offering the procedure, and we live in an era of shared decision making, and so if the patient decides that they want to proceed, then they'll get the device. If they decide that they do not want to proceed, then I'll just maintain them on, long-term oral anticoagulation. Personally though, I would never prescribe it to a family member. If one were to ask me, shall we move forward and get this procedure done, I would never say yes. Because the residual quote unquote leak from the device is not trivial, is more than 10% in published literature. And, you sort of end up being on the oral anticoagulant anyways. And, I think also, just thinking about stroke, I think there's more to it than just the left atrial appendage. I think there's more to the systemic inflammatory milieu that propagates thrombosis, and I think solution to a systemic phenomenon is a systemic medication which will make certain that you have adequate anticoagulation to prevent thrombotic events. That is just my own intellectual take on the subject, and I think just thinking that you're going to occlude an appendage or a structure which is then going to prevent long-term stroke is too simplistic in my mind. So I wasn't too surprised. As a matter of fact, I had been wanting to do a network meta-analysis of looking at left atrial appendage occlusion versus warfarin. This is how the device was approved. And then looking at warfarin and DOACs, because there wasn't a head-to-head comparison until this study, looking specifically at DOACs versus left atrial appendage occlusion. I had been wanting to do one for at least 2-3 years. And so when the results were presented, and I know that we're still waiting on the paper to be published, I know it's going to be a highly controversial acceptance. I was sort of, I don't want to say vindicted, but I sort of was like, I wasn't surprised. I was not surprised. So, and like you mentioned, the practice of prescribing left atrial appendage occlusion closure in the US is rampant. There are sort of programs built on it, and I question the utility of the device. And again, like you mentioned upfront, I'm also going to mention upfront that I do have a bias in how I have interpreted these data all these years. Right from Protect AF all up until Closure AF, I've never really found a truly superior signal for the device.
I come at this as someone who doesn't have a dog in the race, as to the English expression. So we don't. I personally am not impacted by the outcomes of whether this is pro or negative. As a clinician, I see patients, general cardiology patients. I see patients who may or may not be better off with one of these devices. When I see these patients who have very high bleeding risk and can't take an anticoagulation, then I do ask the opinions of our EP colleagues. I note that they don't rush to go for these implantation devices here in the UK. We tend to be very selective. That might just be because as a nation, we are quite conservative. As medical practitioners in the UK, we tend to be a little bit slower on the uptake of some of these things. Our system is a little bit more conservative because there are lots of constraints. But I've not seen patients coming to masses of harm because they're not getting these devices. So there's got to be a difference. There's got to be a reason why we're not seeing such profound differences between the two nations. Obviously, we're a much smaller nation. Maybe our cohort of patients is lower risk. Maybe they're more healthy. I don't know. But again, I'm struggling to see where this niche would be, because I'm not seeing such patients with such high bleeding rates that they can't take anything because the medications are good. And in those young patients who have paroxysmal atrial fibrillation, I've got a couple of patients who are keen horse riders who refuse to take anticoagulation because if they fall from a horse, then that could be quite dramatic, and they refuse to take it. In the past, you may think, okay, well, we'll put them forward for a closure device. Well, in the modern era, our AF ablation techniques have got better, and we've just presented a study that suggested that in successful AF ablation, then maybe they don't need an anticoagulant. So theoretically, in that cohort of patients, we've got another alternative way of doing things rather than putting a closure device in. And of course, patients who've got a closure device in, it can be then subsequently tricky to do ablations. So I think maybe we're just looking at this the wrong way around. So I suspect this is a niche device for a niche group of patients, and we've just got to make sure that we're positioning that where we use this best, rather than basing it around marketing and basing it on the vibe of, well, we think this is going to be better, and so this is what we're going to do. It's tricky. These particular study, again, doesn't make it easy to interpret. We've got some areas where the event rates are lower. We're looking at a slightly lower reduction in stroke rates in the arm that has the appendage, slightly higher in the medical therapy arm, but the confidence intervals are crossing one, and so it is then becoming more neutral as an outcome. Bleeding rates are quite high in the medical therapy arm, much higher than in the bleeding arm of the standard DOAC studies. But of course, this is the whole purpose of these devices in high bleeding rate patients. Then, of course, we're looking at complications in the procedure as well. It's not a benign procedure. There's a risk of cardiac tamponade and causing pericardial effusions is quite high, and vascular complications. One of my colleagues always makes these look super easy, but I know that they can have lots of issues. And I've looked at the TOEs in patients who've had these done, and as you say, the leaks are not inconsiderable. And what's always disappointing is when you see the patient back at 6 months and there's a very large thrombus attached to the device, and the plan is to give them a DOAC after we've said that they can't have one. I've personally never found any of this a very satisfying experience.
Yeah, no, I think for the vignettes that you shared and for the reasons you mentioned, I have not been a fan. Yes, I mean, look, in the US, about 500,000 patients have the device already. So, clearly there are adopters, and there are proponents, and there are programs and believers. So, again, I think it's important to. It'll be incredible to read the paper, and look at the supplementary appendix to see if there are subsets which may benefit. But right now I remain unconvinced that this is helping more than it's hurting. So with that, let's move on to. I think it's a good segue for us to talk about new technology in interventional cardiology. I think some may not be new technology, but just maybe a new approach to dealing with disease. I was particularly. I don't want to use the word shocked, but rather not shocked, not surprised, sort of illuminated with what Proctor had to show us. Uh, so I will let you take the baton here, Sukh. Do you want to talk about Infinity first, and then move to Proctor and Solution?
Yeah, of course. Yeah, no problem at all. So let's talk about angioplasty. We're talking about coronary intervention. So again, I'll declare my bias. I'm an interventional cardiologist, so it's my principal job is to put stents into people, and so and that's what I spend a lot of my time doing. So there's not a huge amount of innovation that's happened in this space. It's small, modest changes. We tend to get very excited about things that are small and modest. And for a while, the drug-eluting stents had gotten to a stage where it was very hard to tell the difference between them. And then there is this new product made, the Dynamics spelt as like Dynam and then X, and it's a device that calls itself a bioadaptor rather than a classical drug-eluting stent. Now, I think with respect to the company, this is the power of marketing, and giving it a new name, it makes it sound much more exciting. And for simple minds like me, that this obviously captures my imagination. But essentially, this is a type of stent. But what's nice about it is that it's made with the ability for it to uncouple and to expand over time. So if you imagine a typical stent, you can think of them as a piece of metal that's a very, very fine structure with these kind of large holes within it in order to give it a bit of flexibility. And typically it's a solid structure. Now, this device is different. It's made up of 3 different components that are interlinked together, and a little bit like Legos or another block that your children might play with, they are connected together with these little interconnectors. And over time, they have a bioresorbable polymer. And over time, the bioresorbable polymer wears out and gets consumed by the body. And when that happens, the links between the bits of metal come apart, and so suddenly this stent can now separate from itself. And the idea being, if you've successfully treated a vessel, over time the vessel wants to grow and have a increase in the size of the vessel. And whereas previous drug-eluting stents acted as a rigid cage and would prevent that from happening, that this bioadaptor, I'm saying that in scare quotes, allows it to expand and get bigger. And this has been around for a couple of years. It's been published. There's actually a Lancet paper that showed it worked pretty well in standard lesions from a couple of years ago. And what was presented at TCT, so not that long ago, was the Infinity Sweetheart study, was the use of this Dynamics bioadaptor compared to the Resolute Onyx drug-eluting stent. So this is a really high-quality stent from Medtronic with zoterolimus as its durable, medication that's on the durable polymer. And the idea is that they do this as part of the International Sweetheart Registry, which is a registry that extends across Sweden and other parts of Scandinavia that use a database which follows the patient regardless of where they are and what their outcomes are. And the data collecting is incredibly high quality. This is the kind of thing that can be done in the Scandinavian countries. They tend to be very organized. People tend to pull together. They're more uniform as a culture. And so they get really good registry outcomes. And they simply looked to see what the target lesion failure rate was at 12 months. And they looked at death, MI, and clinical driven TLR. And what they found was this new kit, this bioadaptor, was non-inferior compared to the standard drug-eluting stent. And in fact, there was quite a significant reduction in target lesion failure, both at 6 months and out at 24 months. And what was really quite striking is when we look at the late lumen loss analysis. So these are studies in which they measure the degree of ingress within the stents. They found that when we measure the late lumen loss in these devices, it was very much to the left of the standard Onyx stents, which means that in fact these vessels are growing with these devices, and they're not getting smaller; they're in fact getting bigger, and therefore this is potentially of long-term benefit to patients. So this is a little bit like the bioresorbable scaffolds that we came up with a couple of years ago. The idea that the technology dissolves and goes away, and that the vessel would then be unencumbered. But that particular technology, unfortunately, wasn't so good. It wasn't well used. It wasn't well expanded. Our approach of putting the bioresorbable scaffolds in was really quite poor. Unfortunately, it was a bit of poor practice at that time, and the outcomes were very much negative. That led to a little bit of a setback in the interventional community in our use of those technologies. But now we're innovating, we're coming up with new approaches of how to be able to do this. Now, the other unique component of this, and this will link into some of the drug-coated balloon talks or studies that I'll mention later, was that this bioadaptor contains sirolimus rather than one of the other medications that we tend to put within these stents. And sirolimus has a number of advantages in the fact that it is cytostatic. It may well have some advantage in not damaging the intima and the adventitial lining, and therefore there is some additional late lumen gain that could be gained with the use of sirolimus. So, obviously, as an interventionist, I'm becoming obsessively nerdy about this, but essentially, the upshot of it is that we may overcome some of the limitations of the other drug-eluting stents, that we tend to get late lumen loss, we tend to get restenosis, and we tend to then get restenosis that then triggers this recurrent reattendance into hospital with end-STEMIs with that particular vessel and needing to put stents within stents. And potentially we could get away from that with these new devices. Still too early to say that with certainty. So far, this is the only device of its kind. I'm sure if the market will tell us, because of course the market always decides, and if we start to see other companies producing devices that are similar to this, then we'll know where everyone is going. What are your thoughts?
Yes, I have not seen it in. I've only seen the trial. I have not seen it in clinical practice just yet. I don't know. Do not personally know of a colleague who has used it. I'm trying to think if I know someone who may have used it, but not to my knowledge. And I certainly it sounds appetizing. I think I think part of the joy of being an interventional cardiologist, and I'm sure you can relate to this, is the excitement of new technology. I think it always sort of captures our attention. And so it's always fascinating to read about new devices and new technologies. Again, how this pans out in clinical practice, time will tell. But certainly a neat concept and a neat idea. And have you had a chance to deploy one, Sukh?
I've not personally used it, but a colleague has, and their comments were that it was essentially a stent. Obviously, where men a few words, they said, well, basically it's like a stent. But of course, lots of people said that about the bioresorbable scaffold, and that proved very much not to be just a stent. Partly because it was bulky, partly because I think in that era our vessel preparation approaches were not very good. Our expansion wasn't very good. Our sizing wasn't very good. Our use of intravascular imaging was appalling in that era. So I think that we should really learn from the errors made from that era. And then with these new technologies, just move slowly rather than rushing headlong into something and just putting these devices everywhere. I think cost will be an issue, and inevitably, this is a device that's made by a single company. It's a modest-sized company. Costs will be high. In our particular center, we've got these contracts which are commitment to other devices. We have to make sure we're hitting all of those various metrics in order to meet our compliance. It does make the use of these newer technologies a little harder, but it's certainly an area of interest. We've been thinking about what studies we can do. Hard to be able to think of a study that will be making a meaningful difference. Obviously, our site we're big in coronary physiology. Are we really going to measure a meaningful difference in coronary physiology when in a newly deployed dynamics device? Or I think that's unlikely. Does the vasoreactivity of a vessel really make a difference to clinical outcomes in real terms? Probably not. Hard to prove that. What does increased vasomotor activity in a vessel really mean long term? Hard to know. Will it be a niche product? Almost certainly. It'll be useful to put in patients who've got tortuous vessels, when you've got bridging areas, or you've got areas which the vessel becomes on a hinge point. That you could imagine would be very useful. Very useful at bifurcations, I imagine. But again, we should step slowly and carefully, not rush headlong into overusing this technology and then for the device to fail.
Yeah, no, I completely agree with your take. I think it's cautious, and cautious is the right word here, and also ways of motion was sort of the phenomenon that bioresorbable stenting was supposed to be helping with, and sort of the opposite happened. In terms of heart clinical outcomes and events. So I think open-minded, let the data speak for itself, and just be cautious would be the word here, which I think is a good segue for the next sort of, I want to call it, it's a device. I mean, it falls under the device realm. We're talking about drug-coated balloon strategies. So you want to talk about solution next?
Talk about solution, yeah, absolutely. So there's obviously the last couple of years, everyone and their brother is trying to sell a drug-coated balloon, and it has become this huge race on who can produce drug-coated balloons that are easy to deliver and are effective and have a good price point. I know in the US, they've only recently been licensed for routine use. There was some constraint because of FDA rules. Here in Europe, and certainly here in the UK, we've been using them for quite some time. My experience of them is, let's say in the modest zone. So they certainly have their utility. I like them in certain settings. In others, I feel slightly nervous about using them. The solution de novo study was again presented at TCT. It's a very nicely presented study, and that looked at patients in a multi-center randomized control study, but all open labeled, designed as a non-inferiority study, looking at patients with de novo coronary arteries, so classical coronary disease, mostly straightforward lesions, but some calcific disease, some bifurcations, modest number of proximal LADs, a larger number of mid and distal LADs, as well as right coronary arteries. And they're basically comparing the approach of using a drug-coated balloon approach with a sirolimus-eluting balloon, so the device known as a solution balloon, which is reported to be unique because it has a number of micro particles that contain the sirolimus drug, and that aids its delivery and its local utility without it being lost. Whenever you look at these devices, there's a fine powder. My concern is always, is the drug coming off in your hands as you handle it? Apparently not, and certainly not in this particular device. And what they were comparing it to was a contemporary approach with standard PCI, with standard drug-eluting stent. And what they were looking at was making sure the lesion was well prepared, making sure that there was really good use of pre-dilatation, because that's the principal weakness of using drug-coated balloons. And the primary outcome was target vessel failure. So that's a very sensible thing to do if you're targeting the use of a single technology in a particular vessel. Is that vessel going to close? Is there going to be a myocardial infarction in that particular vessel at a later date? And what they essentially found was in the solution study, the solution de novo, was that the drug-coated balloon was non-inferior to the drug-eluting balloon, target vessel failure. Now, so that gives us idea that we can be randomizing these patients and we can getting safety outcomes. Now, the paper hasn't published yet. I had a little look and the paper still wasn't published when I checked before starting this podcast. Now, the study was relatively modest in size. It's around 3,500 patients or so, with around 1,600 patients in each arm. And the event rate was around 5% in the DEB arm and around 4.5% in the drug-eluting study arm. And it just fell within the non-inferiority zone. But you could just imagine, again, with just a few events moving from one arm to the other, that it would be found to be inferior. So again, it suggests that some of these study results could potentially be fragile. Just a couple of patients moving from one arm to the other could easily drive the events in the other direction. But it does suggest that we've got a new technology that does seem to work better than I would have expected. This isn't the same as just balloon angioplasty. This isn't the same as just standard drug-eluting balloons, such as with paclitaxel. And there seems to be something better with sirolimus and these particular delivery systems. So potentially this could be a novel therapy going forward. In my own practice, I have been expanding my use of them. I was somewhat a naysayer and predominantly using it in stent restenosis only, but actually my practice has expanded and I am using it a lot, particularly in vessels where I think we can probably get away without a drug-eluting stent. And that over time, I imagine my practice will expand and grow. And that's what the BCIS database seems to show. If we look at the data that's collected for all PCI that's performed in the UK, we can see our use of drug-coated balloons has expanded over the last couple of years. And I would expect that that will continue to increase. Here in the UK, we've got a couple of centres who are really adventurous and use it almost exclusively. Now, I don't think I'm brave enough to do that, but certainly I'm expanding my use of the technology.
Fascinating. So in terms of adjunctive medical therapy, so do you still treat these patients with dual antiplatelet therapy? Is there a change in duration now that you do not have a metal that is left in? Can you walk us through your strategy for managing, DAPT in these patients?
Yeah, I think it depends on if you're dealing with a chronic coronary syndrome. The European Society of Cardiology guidance is to suggest 6 months of dual antiplatelet therapy. Now here, particularly in our centre, we tend to stick to 12 months to try and keep it unified across the ACS. ACS is the majority of the patients that come to the cath lab, and people get confused if we have these different combinations. And so we tend to stick to 12 months, but technically ESC guidance is to recommend only 6 months. Now, in this cohort of patients where you've not left metal, in fact, I would just wonder whether you want to keep the antiplatelet on for a little bit longer on the basis that there is potentially disrupted tissue. There is the risk that you may not get the late lumen gain that you think you're going to gain. And so maybe there's merits to continuing antiplatelet therapy for longer. My personal practice has been to use a lot of the data around the utility of single agent clopidogrel. And so for a lot of patients with complex coronary disease or patients where I have a little bit of doubt, rather than keeping them on aspirin, I'd keep them on clopidogrel long term. And that, harks all the way back to some of the very early clopidogrel studies that has shown that in patients with multiple territories with atherosclerosis, clopidogrel is better than clopidogrel alone. In some patients who have bleeding issues or high bleeding risk, and you're using this approach to get away with less antiplatelet, I'm not sure we've got that. I'm not sure we got that data to support that, but it'll certainly be something that you could try. Remember, around a quarter of the patients have a vessel dissection that still requires a bailout stent. So this is a study that looks at strategy, but not absolutely the intention to treat. Because a lot of these patients in the DCB arm did end up with a stent, so a little bit tricky to unpick.
Yes. Well, the percolation of drug-coated balloons has not occurred in the US as it seems like as much as it has in the UK. So I wonder how it will change or impact our practice. I'm certainly looking forward to using them. I know that at my institution, we now have gone through the regulatory paperwork so that we can start having access to these balloons, and there is now a separate CPT code so that it does not get quote unquote sort of like reimbursed or billed as balloon angioplasty. It's sort of like you mentioned, is much more than just your what we call as plain old balloon angioplasty. So moving forward, let's talk about Proctor. I thought the results were illuminating, is the word that I used. I want to say I was a little surprised, a little wowed, but I will have you discuss the results for Proctor.
Yeah, so this is so for those of us who end up taking on cases that other people rather not do, this is a study for them. So this is the concept of natal vessel PCI versus treatment of a saphenous vein graft. So many patients are sent off for bypass surgery. And one of my big bugbears is that patients who are in their 40s and in their 50s get sent off for bypass surgery because they've got so-called three-vessel disease. And then what happens is their own arteries, their native vessels, have accelerated atherosclerosis, and usually they get obstructive disease in the vessels that probably wasn't obstructed before, probably wasn't critical, certainly. And then these patients end up having some form of representation. They either have ongoing ischemia proven with MRI, or they have ongoing symptoms. And then the question is, well, what do we open? Do we open the native vessel, or do we open a vein graft? Now, vein grafts degenerate after around 5 to 8 years. We expect a lot of vein grafts to become significantly degenerated. We know that intervention to a vein graft is fraught with issues. Vein grafts don't tolerate stents very well. Once a vein graft is touched with a stent, our feeling is that vein graft is not long for the world, and there is a high risk of closure of that vein graft. And there tends to be a lot of clot, and there tends to be a lot of other disgusting matter within vein grafts, which tends to embolize at the time of vein graft PCI. And so it was, for the last few years, those in the CTO community have been really pushing the thought that we should be focusing on opening the native vessel. And certainly what I have generally tried to do in my own practice is, particularly in these patients who've had early bypass surgery with early graft failure or degeneration, is that that's a really good time to open a native vessel, because it's not been that long. The native vessel isn't fully calcified and closed, and there's usually still a clear antegrade path, which makes it relatively straightforward to open the vessel. And I've tried to do that over and above vein graft PCI, principally because if you do the vein graft, we know that the vein graft will close, clot off, and then you'll have no option at the next patient presentation. Now, this study looked at exactly that question. So, but unfortunately, it showed that our approach appears to be wrong. So what they found was they randomized patients who've been through a heart team discussion, because either an approach to the native vessel or the saphenous vein graft are equally feasible. And then they randomized to either native vessel PCI or to PCI to the vein graft. And they looked at MACE events at a year. And what they found was that the MACE rates were actually higher with PCI to the native vessel compared to the saphenous vein graft. And there were much higher rates of post-procedural myocardial infarction and much higher rates of repeat revascularization when done to the native vessel. There was no major difference in mortality, as we would expect, because these are relatively stable cohort of patients. They've survived surgery, and so we'd expect them to be able to survive coronary intervention. Now, this is the opposite of what we would have thought. What we often found is that the procedures to the native vessel were much more complicated. They require CTO approaches, usually requiring much more heavy-duty wires, with the inherent risks associated with that, with supporting catheters, deep-seated techniques, longer procedures, much higher contrast use. Whereas vein graft PCI was quite simple. The lesion length that was treated was almost always shorter, and they used embolic protection devices, but not to a huge amount. Actually, my personal experience with these embolic devices isn't great either. And when you pull the basket out, there's rarely anything in it. But they found, and these were predominantly stable patients, so that there wasn't the acute thrombus that you might see in an end-STEMI patient. So this study therefore kind of upturns our assumption that we've been working on and the CTO community has been talking about for the last couple of years. Now I think there's a few things about this that we should just be cautious. Whenever you do a study like this, in which a patient could equally go into either arm, then you will automatically bias the outcome against the more complex approach. So if you've got a patient who's got coronary disease, so obviously our centre, my colleague Professor Rasha Alami did the Orbiter study. If you have a patient who has got relatively simple lesion that is causing angina, and you could treat that with PCI, or you could treat it with with medical therapy, the treatment approach that has the least risk, i.e., giving tablets, you will bias towards that. And in this particular setting here, we will find that we will bias towards the vein graft intervention. The stenting that was done to the vein grafts was relatively straightforward. They were basically just putting in a single stent into the vein graft, and the techniques that were used were quite simplistic. And so you could imagine a short-term follow-up at a year that you will not unpick the degeneration of the vein graft and thrombosis of that vein graft over time. And you won't unpick the inherent issue that young patients who have had bypass surgery at a young age all have, which is their native vessel occludes. So yes, you can make yourself happy that we've done a simple procedure up front, but this patient's outcome longer term is still impacted by the fact that their native vessels will occlude. Now, it's hard to prove. It's also, these patients are patients who are suitable for either. And so by taking that group of patients, you're then now going to basically disadvantage those patients who are not suitable for either. So what doctors and we as a cardiology community tend to do is look at this headline result and say, oh, okay, everyone should stop doing native vessel PCI. It's a waste of time. There's no evidence for CTO anyway. What are we doing? Do nothing, do medical therapy, or just put a single stent into a vein graft. But by doing that, we'd strongly disadvantage those patients who could have had benefit. It's hard to prove that benefit. It really genuinely is hard, because I, as a jobbing clinician, as someone who actually treats patients, find it hard to randomize patients who would potentially make the difference in a study, because it is generally hard to say to a patient, you know what, I think that this is best, or what I'm going to do is allow a coin toss to be able to decide that for you. Now, this is the same thing that happens to all patients going into all randomized control studies, but particularly in this cohort of patients where the operator and the skills of the operator and what they do in the case is what drives all of the events. If you are taking a rather simplistic approach, I suspect you'll do them disservice a little bit later on down the line. Hard to prove in a study, though. I'd be interested in your thoughts.
Yes, so the headlines were surprising. I was of the same school of thought that in a degenerated vein graft, approach the native vessel and revascularize the native vessel. That I think also from an intellectual perspective made more sense to me intuitively than going after a vein graft because of the reasons you mentioned. And so the results, now I'm not sure if the paper's published. If it has, I've probably missed the paper or I've not read it. But the results were counterintuitive to what I thought, well, I will see. I think what you bring up is an important point, that maybe these patients were suitable for either. Either you go after the vein graft or you go after the native vessel PCI, you'll get a decent angiographic result. I think what becomes tricky is extrapolating these findings to patients who would be suitable more for a native vessel PCI, that the vein graft is so degenerated that it's going to be harmful to go after a degenerated vein graft. And we see that not infrequently in patients who are referred for angiography and bypass graft angiography in our cath labs. Some of these vein grafts, they're completely thrombosed and stenosed. And so I would be, just like, and you know what I'm talking about as an interventionalist, when you sort of see these, lesions angiographically, you're like, no way, I'm going to go after this. Let's just treat the native vessel.
Yeah, so this is a huge problem that we have in the community, right? So when we have bypass patients, you and I both know that there are patients are less likely to be offered coronary angiography full stop if they've had a prior bypass. they're less likely to have testing. It just seems to be a cultural thing that exists within the cardiac community. There seems to be a thought, well, you've had bypass, of course you're going to have these little events. And the idea that the vein graft then covers, or the arterial graft covers all of the events that could potentially occur within the native vessel, it doesn't really matter. But we see these patients at the end when they're end stage and they get referred back to us, and someone says, please do something. And it's very hard at that point to fix the issue. But so the paper has been published, and it came out in JACC, and it is a detailed paper. I think it is the cohort of patients that they've selected are fairly complex. The pre-procedural TIMI flow grade in patients who are having native vessel PCI was 0 in 70 patients out of the 108 in the native vessel PCI. So, they're working with completely occluded vessels and then going on and having complex PCI. In many of the cases is a complex retrograde approach. I think I can understand where the naysayers would say, they say, oh, well, you're spending a long, long time here trying to open vessels that are fully occluded to no apparent benefit. I think the point I'm trying to make is that perhaps with appropriate case selection, and perhaps in patients who have an opportunity for this to be fixed before they end up in this late stage where they've got no other option, it is a good idea just to open up the native vessel. It's tricky because, again, it's we won't be able to prove that in a study, and haven't been to date.
Yeah, no, I agree with you. I think individualized approach is the best strategy here. I mean, if you have a patient who's maximized on optimal medical therapy, blood pressure is on target, heart rate is on target, you have a lesion which, if you think is subtending a substantial portion, or a significant enough portion of myocardium, and you think revascularizing that lesion is going to offer symptom relief, then by all means, offer. I still want to err on the side of native vessel PCI because, some of the degenerated grafts I've seen, what I'm talking about.
I tell you what, if the viewers have or the listeners have an opportunity to just download the paper, there's the very first case that they show in figure 2 of the paper, I think, typifies this completely. There's a massive vein graft to a right coronary artery, or with a native right that's 100% occluded with a flush CTO from the ostium, and there is a single lesion in the proximal vein graft to the vein graft to the right, and otherwise the vein graft is absolutely humongous. And you can imagine putting in a 4.5 or 5.0 stent in this vein graft used by IVIS guidance would have an excellent outcome, whereas spending 4 hours trying to open a flush osteo-CTO occlusion via a retrograde approach is clearly going to be a disadvantage in terms of troponin elevation because of the procedure length. So, again, if you select a patient like this, you're going to drive towards the negative outcome here. You're going to show that your native approach is not going to work. Again, I just caution my CTO colleagues just to make sure that when they select patients for these studies, that they select appropriate patients rather than something to, trying to prove a point, because when that happens, it always comes back and bites you on the bottom.
Yeah. Well said. Well said. Let's move to, from intervention, let's move to prevention. I think all of us will probably not have these conversations if we're taking care of our, our metabolic and inflammatory and thrombotic milieu by prevention strategies. So, you've picked a couple of studies there that you want to discuss, Sukh, just to wrap up the episodes.
Yeah, for sure. So probably worth talking about these because certainly I don't know what your practice has been like or what it's been like on your side of the pond, but probably the number one drug that people come and speak to me about as a cardiologist now are the GLP-1 agonists. And the question whether it's up front when the patient first walks in, or whether it's something they're saying while their hand is on the door handle on the way out, there is a huge desire for patients to be given either semaglutide, or as I'd pronounce it, semaglutide, or Mounjaro, or Zepbound, as I think it's referred to as in the US. These GLP-1 agonists have been the drug of the last couple of years, and the data for them has increasingly become very strong. So the story, as many listeners will know is these are medications that have actually been around for quite some time. They were developed as diabetic medications. The cardiovascular outcome studies that were mandated by the FDA have long shown that there is some cardiovascular benefit. Dulaglutide was one that showed a cardiovascular benefit some time ago. And there are a couple of GLP-1 studies that have come out this year that just help support our utility of them. I just want to mention SOUL, which is an oral semaglutide study in type 2 diabetics with proven atherosclerotic disease or with CKD. Majority is atherosclerosis. And they took around 9,600 patients who've got long-standing type 2 diabetes with known atherosclerosis and randomized them to oral semaglutide versus placebo, and they looked at 3-point MACE, stroke, myocardial infarction, and cardiovascular death. And there was a risk reduction therapy of risk reduction of around 15%, so a hazard ratio of about 0.86 seen over 4 years. Modest absolute risk reduction, but a definite reduction in relative risk. And the reason that this study is worth mentioning is that there are patients who can't take GLP-1 as injectable therapy, and it's very nice just to see that there is a cardiovascular benefit from patients on semaglutide or semaglutide as an oral medication. And the reason I mention that is certainly here in the UK, the medications are prescribed by the primary care physician, so the general practitioner. The purse string for the drug budget is held in primary care. As a cardiologist, I'll see a patient and I'll say, please, I think this patient will gain benefit from a GLP-1. And although our health secretary or minister responsible for health has been saying that, they're going to make these drugs widely available, the simple reality is that these patients come back being told that they are not allowed to have them. The GPs have said no because the costs are very high. Well, oral semaglutide has been around for some time. We know it's well tolerated. It can be given at either 7 or 14 milligrams orally. And now we're seeing that there is cardiovascular benefit in type 2 diabetics with cardiac disease. And so actually, again, that just points us to advise our primary care physicians to start medications they feel comfortable with, are familiar with. They've been using semaglutide orally for a number of years. And so we've just got another little bit of data that supports that. And then in a similar vein, the SURPASS study was published. So this is the tirzepatide. This is the underlying drug that makes up Mounjaro or Zepbound. And this was compared to dulaglutide. So this was looking for cardiac benefit from Mounjaro. Now, many of you will be familiar with prescribing semaglutide, proven cardiovascular benefit shown in the SELECT study that I think we talked about last year. But Mounjaro hadn't got that data, hadn't published that data, but that's shown in this study. What they did was they compared it against dulaglutide, which has an established cardiovascular benefit, proven to have a benefit, and they did this as a non-inferiority study. They showed that they were non-inferior to dulaglutide. It's been around for a long time. On 3-point MACE, the absolute risk reduction again was very small, unfortunately very small, but there was a reduction in the hazard ratio down to 0.92. It wasn't superior. I think I'm sure the company was hoping that the drug would be shown to be superior, but it's a high bar because, of course, this is against an active comparator, whereas the SELECT study that was done in cardiac patients last year was against placebo. So this is a cardiovascular outcome study for Mounjaro that shows there is a reduction in cardiac events when compared against dulaglutide. And so these two studies basically help convince us that these medications are preventative, that they reduce cardiac events, and that in patients who have type 2 diabetes, which is just a rampant epidemic, which really we're nowhere close to fixing. Potentially, we have a risk reduction therapy that we should be recommending. And even if we're cardiologists and we may not know all the ins and outs of type 2 diabetes, we can certainly recommend these medications to our primary care physicians and ask referrals into endocrinology or diabetologists to see if they would initiate these drugs. I don't know what your usage is of it, but certainly this is a daily question that I'm asked. And so I thought I'd just mention these two studies.
Yeah, this did become sort of like what I call the drugs du jour. Um, everybody's asking about these. Not only patients, even family members are asking about these, and you're sort of everybody's trying to find an indication where these drugs are covered, so that they can start using these drugs. They certainly have benefit, no question. I think what I've struggled with is the amount of medications that are now available with a class 1 indication for our patients. And I look, I mean, I'm a physician. I'm an internist and a cardiologist and an interventionalist, and we're taught to prescribe medicines. Um, and part of me also wants to address the underlying problem, which is, are we living our lives the way we should be living them, in terms of how we're eating, how we're moving, and how we're sleeping. And I think that is sort of the conversation I want to have. I do have with patients before, typing the drug and, sort of sending it to their pharmacy, which, may take less time. Um, and I genuinely wonder, like, at what point in time are we going to stop adding more to the armamentarium for our patients? I mean, if you think about it, where you have an antiplatelet agent, you have a statin, if they're statin intolerant, you have a PCSK9, you have an SGLT2I, now you have a GLP-1. I'm sure we're going to come up with studies which are going to show LP little a lowering, prevent sort of prolongs life, and then there's going to be that. Um, and this is, I'm just talking about a chronic coronary syndrome patient who otherwise may not have high blood pressure, may not have diabetes, or, you know, hyperlipidemia or mixed atherogenic dyslipidemia. And if you sort of add those comorbidities, which you and I know are very common, I mean, you're easily dealing with a drug list which is at least 10 medications, if not less, or if not more.
That's absolutely right. Yeah. So, I mean, this is the key question for modern society, isn't it? So, when should something become a medical problem versus a societal problem in order to try and prevent things? And unfortunately, at the moment, the incentives and the way that society is structured, it is that it's not incentivized to have people being healthy because of the calorie density of our foods, the way that our towns and cities are structured. It encourages sedentary lifestyles and behaviors. People are working predominantly from home now, from home offices, rather than commuting into work. Certainly, and if they are commuting in the US, they're going to be commuting by car, and so they're not increasing their activity levels very much. And then the food that they're having is going to be very calorie dense, and so all of this is very, very tricky to be able to change. It's very hard as individual physicians to make that change. Obviously, we want to have that conversation with patients, but certainly our time slots here don't really allow it. Even in patients, for example, in our private service here in the UK, we have our National Health Service, and then there are some patients who may use their own health insurance coverage or self-pay to cover for a private. We have more time. But even in that setting, it's not always easy to unpick all of these different things. I've noticed huge successes in highly motivated individuals and people who really want to make a difference. And people really do change and really can make that. But it is hard to do that for everyone. And there are lots of different things that come into it. And so, yes, unfortunately for us, many of us will err on the side of giving a pill or a jab, but maybe all of these things could come together as maybe a little bit of an eye-opening thing for overall society. I think over the last couple of years, society had started to accept being overweight or in the obese category as a lifestyle choice. And maybe this was done out of kindness. This was done out of allowing people to be themselves, so to speak. But I think the advent of these medications has altered that dynamic, has altered that conversation. That is a little bit beyond my level of training and understanding to be able to unpick. But certainly, your key question of polypharmacy could obviously be solved by if we had polypills or polyjabs that could be able to resolve all of these issues. difficult. Obviously, in the West, where we have all of these excess calories, this is a problem. Then in developing nations, for example, in the Middle East and in the Indian subcontinent, type 2 diabetes and obesity is becoming rampant. And that's as countries become more and more affluent, and access to calories and lifestyle changes seems to drive to this approach. Maybe if we had people tilling the land and doing more manual labor, this wouldn't be the case. But it may require quite a catastrophic societal change for us to be able to make that difference.
Yeah, no, I agree with you. But no, thanks. Like I said, like you said, this is the most talked about drug, has been now for the last 2 years. So moving on, I mean, you want to talk about the last quick mention?
So I just wanted to just mention on these new medications, and I really, this study in itself is a little bit complicated, and I have to say I'm not really sure where the clinical utility will come, but I just leave this here as a tantalizing thought for the future. So this is about the core TIMI 72 studies. So this is olezarsen, which is a injectable therapy that is a antisense oligonucleotide that's against apolipoprotein C3. And apolipoprotein C3 is linked to altering lipoprotein lipase activity, and that determines how much triglycerides we have in our blood. And you will have all seen a small number of patients that have super high triglycerides that just don't respond to anything. I can think of just a couple of patients on my books who I've had over the years who've got genuinely very high triglycerides. And values, as we know, values over 3 in UK numbers, so that will be something over 200 milligrams per deciliter in US numbers, are elevated cardiovascular risk. But as the values go up, there's a lot of risk for pancreatitis, for getting gallstones, and having these kind of abdominal complications. And we don't have great meds for them. There's been statins have a modest effect on your triglyceride levels. Fibrates have a modest effect as well, but again, tolerability issues, and nothing seems to reduce the triglyceride levels enough to stop pancreatitis. This is a set of studies that have shown that these injectable therapies that are highly targeted to the expression of ApoC3 leads to huge reductions in your triglyceride levels, and importantly, also then the clinical sequelae from triglycerides, which in this particular study was to look at acute pancreatitis. So this isn't something that we as cardiologists are routinely seeing. But the reason I wanted to mention this just is the beginning of this sea change in medicine. And you mentioned the medications. There's a lot of priming the pump at the moment, as all the different pharmaceutical companies are currently studying their anti LP-little-a medications, which may or may not have a clinical benefit. There are all these other medications that are going to be targeted anti-oligonucleotide, antisense oligonucleotide medications. And you can just imagine in the future, this idea of polypharmacy will become an aspect of the past, because you'll turn up for your 6-monthly jab, in amongst all your other jabs, you basically block all of these deleterious proteins that are being manufactured in your body, and you can go away and do whatever you like for the next 6 months, as it's a solved problem. And I think this is where really, medicine 3.0 really is going to be, rather than giving everyone 8 or 9 pills as for risk prevention therapy. I think this is what the future will really be.
Yeah, it's exciting to think about it. It's exciting to think that it's just one and done, as they call it, right? I also futuristically predict that there will be a day when I think all we have to do is deliver some clot busting medication or some anti-proliferative, anti-lipid medication down the coronaries using a catheter, and nanoparticles will do the rest. And our scaffolds and balloons will be a thing of the past. Of course, I'll be wrong. I may be wrong. That's okay, but I think that's where the future is headed. Well, Sukh, this has been a fascinating conversation, like always. Thank you for making the time on a weekend. I know you're visiting family for the holidays, so I really appreciate you sparing some time for us and educating us. The year-end episodes are episodes that I look forward to because it sort of summarizes the year for me, as it does for our listenership. Do you have any closing remarks for Parallax before we say goodbye?
Well, I just want to say thank you again for the very kind invitation. It's an honor to be able to speak with you. I hope the audience found it helpful. I'm always open to feedback and hearing from people. I'm sure I've got I'm just scrolling through my list of, I think I looked at 60 different studies that I could have mentioned, and I produced brief summaries just in case we touched on any of them. But, obviously we could do deep dives on any of these things, but if I'm just, it's hard to cover everything in detail. And I don't know about you, but hearing the numbers over a podcast, I find it hard to mentally process it, to just to give you a flavor of the studies. But I'm always very happy to speak to you about it, and I hope the audience finds it helpful.
Yeah, no, likewise. And I think, I agree with you. I mean, there's so much that comes out, every year, particularly a bolus of novel information at ESC, which, like you said, has become the flagship meeting for cardiology, I want to say. And so, and then there's obviously, ACC, there's AHA, there's TCT. There are other subspecialty conferences now, which are well attended. ESCVI was very well attended. We'd even broach a lot of the imaging studies. I think for the audience, please share your feedback with us. If you want us to include and discuss a certain topic, certain studies, then I'll be more than happy to bring Dr. Nijjer back on the show. We can do this, not at the end of the year, but not only at the end of the year, but also sort of in the middle of the year to catch up on the bolus of information that we get each year. But I think from all of us at Parallax, very happy New Year. Thanks for tuning in. This will be in season 8, or depending on when you're listening this, we are in season 8. If you have any feedback for us, do share it on social media. We value your feedback tremendously. And until other Monday, we'll see you soon.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.